This production is brought to you by the University of Edinburgh.
Good evening, everyone. I think we'll start. It's just 6:10. So, welcome. My name is Siddharthan Chandran. I'm the director of the Centre of Clinical Brain Sciences, and we're the host for today's lecture. So this is the 6th lecture in the Edinburgh Neuroscience Christmas series, and I think the 3rd one, which is a public lecture. Despite the weather, it's terrific to see so many people here. Particular thanks to I know quite a few 5th and 6th formers here from the Widening Access Programme. Some heads nodding, that's great. I'm impressed that you're here. We also have representatives from the Stroke Association and Chest, Heart and Stroke Scotland. You're all very welcome and thank you for coming. I think you'll be pleased that you braved the weather to come, because we've got two fantastic speakers who are speaking as a double act, so to speak. Professor Martin Dennis and then Professor Peter Sandercock. They may be known to some of you, but both of these individuals are pioneers in the field that they're going to talk to you about. And the thing that unites their talk is the problem of blood clots. And it's just the geography of the blood clots, whether they're in the vein or in the brain. Either way, it's a bit of a problem, as I'll tell you. But not only have they characterized the consequence of this, but even more importantly, they've absolutely led the way in terms of treatments and how to diagnose this and how to treat this. So we're very fortunate indeed to have them both speaking. And so I'd just like to welcome Peter Sandercock. Thank you very much.
Well, thank you very much for the introduction, and a very warm welcome to everybody. So you may be slightly puzzled by the pictures, and I hope by the end of the talk you'll understand why there's some stockings and what that funny thing on the right is. So I'm Peter Sandercock. I've been interested in stroke for rather more years than I care to think of, and I've been very interested in trying to find a treatment for somebody who's just developed the symptoms of a stroke. So what I'm going to do is take you through the initial phases of, if you like, the journey, for want of a better word, when a person suddenly develops symptoms that might be a stroke. And then Martin will take you through the second half of the journey once you are in hospital, tucked up in a stroke unit. So we kind of cover both time and space. So to begin at the beginning, the first thing we need to be clear about is what is a stroke. And for a lot of people, they're not quite clear whether a stroke is something that happens in the heart or in the brain, but it is fundamentally a problem in the brain. And the brain needs a lot of blood. It needs about 3 cans of Foster's volume of blood per minute to keep it going. So if a bit of brain doesn't get enough blood, it stops working very quickly, and the longer it's deprived of blood, the worse it is. So the next thing is that time is a very important factor in the early phases of a stroke. So time is brain, need to act fast, and I'll explain what that's about in a bit more. I'll then go on to say, okay, if you've got a stroke and it's due to a blocked artery, how do you treat it? How do you treat it with clot-busting drugs? And if you can't unblock it with drugs, can you pull the clot out? And then I'll pass over to Martin to think about what happens next and what's all this stuff about clots in the legs. So, as I said, a stroke occurs because the bit of the brain that matters suddenly loses its blood supply, either because the artery that takes the blood to that bit of the brain has burst and has started bleeding into the brain tissue, which stops it working, or because its blood supply is obstructed by a blood clot, which means it doesn't get oxygen and glucose, the things it needs to work. So the symptoms of a stroke will clearly depend on which bit of the brain is affected, and I'll describe that in a bit more detail in a moment. And the other key point is that most strokes, about 85%, are due to a blocked artery. So I'm not really going to talk much more about strokes due to bleeding in the brain. So the symptoms, so if the stroke affects the part of the brain that moves the face, then one side of the face will suddenly fall or look different to the other side. If it's the part of the brain that deals with the control of movement in the arms or the legs, then one arm may be weak or one leg may be weak. The speech may be affected, it may be slurred, you may be unable to speak, or the words may come out wrong. And then time time is brain, you need to act quickly. And there have been several campaigns by Chest, Heart and Stroke and the Stroke Association to make the public more aware of what are the symptoms of a stroke and how you need to act quickly. And we've even had an ambulance parked around Edinburgh with the face, arm and speech test on it, just to make people more aware of it. But it is important that you act quickly. So what happens when you arrive at hospital is that you need to have a scan to figure out what sort of a stroke it is. So we've got 3 pictures here. Actually, we might need to put the lights down a bit at this stage. Here we go. So that you can see the scan slightly better. So here, that's a normal brain with 2 halves. So it's like you've sliced the brain across like you might your Sunday morning boiled egg. And so there we can see the 2 halves of the brain that look normal. But here's a brain with a big blood clot in one side of the brain, which is obviously causing a lot of trouble. Here is a brain where the stroke is due to a blocked artery, and these brain cells are not only dying, but they're also swelling up, which is causing an additional problem. And they're doing that because they're not getting oxygen and glucose and the things that they need to keep them healthy. So where do these blood clots that block arteries in the brain come from? Well, about 1/6 of all strokes due to blocked arteries occur because a person develops an irregular heartbeat, and because the heart is not beating efficiently, then, as Martin will explain, if the blood's not flowing rapidly, if it's lying around in a rather sluggish pool within the heart, then it may clot, and a clot forms in one chamber of the heart called the left atrium, and that can then suddenly break off and travel through the circulation and end up in the brain. As we get older, and if we've been smokers and had high blood pressure and eat too much fat, then the arteries in the neck can become atherosclerotic, and I'll show you a picture of one of those in a minute. But either way, no matter where the clot forms on the arterial side of the circulation, it gets carried up to the brain. It gets carried to other organs, but it's the brain that matters. So this is a picture of the side of the neck, and I'm sorry, it's a bit anatomical, but if we're looking at the side of the neck, there's the artery that goes to the front of the brain is called the carotid artery, and you can see it coming up here, and there's a branch that goes up into the brain. And if we look at inside an artery of somebody who's unfortunately died, we can see there's something not quite right here, and this is a plaque of arterial hardening or atherosclerosis, and you can see that there's some red stuff glued to the surface of this nasty bit. The rest of the artery is nice and smooth and normal, and that's where the problem arises. And what happens is, so there's the problem, and that's roughly where the corresponding spot in the artery in the neck. Fortunately, if we find one of those in a patient, you can have an operation to remove it, which then prevents you having a stroke. But if you're unlucky and the stroke occurs before we found the plaque, the blood flow will carry the blood clot up into the brain and cause a blockage of a blood vessel. Sometimes the blood clot doesn't go into the brain, but actually goes into the artery at the back of the eye, and what happens is you suddenly lose the vision in one eye. And this is what you would see if you looked with an ophthalmoscope or a retinal camera and take a picture of the retina, and you can see here's the artery here, and you can see there's a little white thing there, which is the blood clot, the remains of a blood clot that block the blood supply to that bit of the retina. So blood clots can go to the brain or the eye and cause a problem. So if the blood clot goes to the brain, as it did in Winston Churchill back in 1949, I'll illustrate what might have happened. Now, obviously, in 1949, we didn't have brain scanners. I'm not going to show you what Winston's scan looked like, but just as an illustration. So we take an X-ray or take an MRI scan, and with an MRI scan, you can visualize the flowing blood, and it shows up as these white lines. So that's what it looks like when it's normal. You've got blood flowing up the carotid and the vertebral arteries here, and going into both halves of the brain, and it all looks nice and symmetrical and normal. and then bang, suddenly an artery gets blocked, and so all of that brain tissue is no longer getting blood to it, and that's what causes the trouble. So if we then, that's where the block has occurred. That's where, so you can see that these arteries are quite small. These are just a few millimetres across, and so the blood clot doesn't need to be very big to cause quite a significant problem. So if we then took a brain scan within a few minutes or an hour or so of that blood clot blocking the blood supply to this bit of the brain, the changes are quite subtle but nonetheless definite. So on this side you can see a white area, a paler area there, which has become distinctly fuzzy. So that says this bit of the brain is getting sick quickly. We've still got time to act and to rescue that bit of brain if we can resupply it with blood. The technical term is reperfuse it. If you don't, this is what happens, and the brain cells die and swell, and that causes all sorts of problems and may actually end up fatally. So again, if this starts to happen, we can do major surgery to relieve the pressure on the brain, but we'd rather not do that. We'd rather treat the brain at this stage when it's still rescuable by simpler means. So Winston Churchill received fairly basic care. Curiously, attitudes to stroke in 1949 were very, very different. And in fact, he had a stroke while he was Prime Minister. He couldn't speak. And the fact that the Prime Minister was unable to speak clearly was concealed from the general public. So it's a completely different world that we live in now. This was completely the opposite of early recognition and early treatment. So there he is being supported by Marshal Tito, and you can see that he's having to walk with a stick because he is quite disabled, and he does look quite frail there. So moving forward rapidly to 2011, things are completely different. We now know that we need to recognise the symptoms of stroke quickly, to make a 999 call, to get straight to hospital, while there's still time to rescue those brain cells. We now set up, if you arrive at any of the hospitals in Lothian with symptoms suggestive of a stroke, that the ambulance know to bring the person quickly to hospital. Hospitals will often be pre-alerted by the ambulance team that there's somebody with a stroke on the way, so that they can be set up and got into the scanner quickly. You can then do some simple checks to see whether it's okay to give a clot-busting drug. Firstly, you need to get in very early, and if the symptoms of the stroke began while the person was asleep or a long time ago, more than 4 hours, then it's not sensible to give clot-busting drugs. And it's not sensible to give clot-busting drugs to people who are at very high risk of bleeding, because if you remove blood clots, you increase the risk of bleeding. So if it's okay, if the scan looks all right, and if there are no reasons not to give the clot buster, you give it immediately. And that's fine. And this is what the arteries look like. So here's a person who's got a stroke, the block is there, the arteries, so there's no arteries here where there should be. They've been given a clot-busting drug, and that bit of the brain is now getting blood and oxygen, and the patient makes a good recovery if you can achieve that. However, strokes don't just occur in older people with hardening of the arteries or irregular heartbeats, and you can't always give clot-busting drugs. So 3 years ago on Christmas Eve, a 29-year-old woman in a hospital nearby at 6:20 in the morning had the happy event of delivering a healthy baby girl, her third child. She was fine after the delivery at 8 o'clock, so that's a little while after her baby was born. She walked to the shower, and then at 8:40, that's at 2 hours and 20, sorry, at 8:40 she was found collapsed in the shower. So when you're assessing a patient with a stroke, what you need to know is, when were they last known to be well? What's the longest time ago that this clot could have hit the brain? Well, the nurses saw her walking to the shower at 8, so we're just 40 minutes in. It might be less than that, but it's 40 minutes at the most. She was found to have paralysis of the left arm and leg, and she was taken immediately for a scan of the brain. And you can't see it very clearly, but the brain actually looks quite normal on both sides. So we got in at the time to intervene, and you can actually see the blood clot sitting there, the culprit, the thing that's blocking the artery. But the problem is that because she's just had a baby, as you perhaps know, people who've given birth can develop a complication called postpartum hemorrhage. That is, they bleed from the womb. And so this is one of the prime groups of people, women who've just given birth, whom you can't treat with clot busters because of the risk of major bleeding from the womb. So the patient needs to go to have an X-ray of the blood vessels to see if the blood clot can be pulled out. And so if you have a blocked drain, you call for Ed-Neuro, who will come along to your drain and they'll put some chemicals down it, so if you like the chemical equivalent of a clot-busting drug. And if that doesn't work, he comes along with a pair of tweezers or some sort of thing to pull out whatever's blocking your drain. Fortunately, we're a bit more technological in the NHS. So you won't get Ed-Neuro, but you'll get taken to an angiogram suite where this sort of kit will be able to take X-rays of your arteries and see what the problem is and where the clot is and whether anything can be done about it. So this was her artery. So here's the blood coming up the artery, and then it stops dead here because there's a blood clot blocking the blood supply. So how do you get a blood clot out without doing a major operation? Well, it's very clever. You take a device like this, and I'll show you a picture of this, but you can come up and see the device afterwards. That's £2,000 worth of kit there. And the business end is in here, that's another £2,000 worth, and I'll show you that at the end. But this is what it looks like. So it's a dyno rod for the brain. So what happens here is that this is a soft plastic tube with a business end. And when you start, this little device at the end is inside the soft plastic tube. So you have an injection in the groin, and you put the soft plastic tube, a catheter, in through the artery in the groin, and then you feed it up under X-ray control until it goes up to the bit of the brain where you think the blood clot is. And then you, what's called, deploy the device. So you push on the wire, this thing here, and this little thing pops out the end, and that's what it looks like. So as it comes out, inside the soft plastic tube, it's a straight piece of wire. But as it comes out, it turns itself into a corkscrew that actually catches the blood clot like that. And you then pull on it, and you don't pull the blood clot into the tube, you just pull the whole thing out. And the blood clot, if it all works, should come with it. It doesn't always, and unfortunately in this patient's case it didn't, but and the technology is moving on. At the moment, this is not something that is freely available on the NHS for the very simple reason that actually it's still very much a research device. We don't know whether this is really the best way of dealing with it. It's an exciting development, and we'll be doing trials to find out if you've got a blood clot that's causing a stroke that can't be treated with clot-busting drugs, whether you should use this sort of device or not, because it can perforate the artery. It can take an awful lot of time, it takes an awful lot of staff, and there may be better ways of doing it. But it's certainly a very exciting development. So, once you've had your blood clot busted and your blood clot pulled out, or if you haven't, because not only a small proportion of patients need that sort of treatment, you'll then be taken to a stroke unit, and this is the stroke unit at the Western, where an experienced stroke physician will be waiting to look after you and thinking about clots in your legs, amongst other things. So I'll hand over to Martin at that point.
Thanks very much, Peter. So when you arrive on the stroke unit, you may well be paralysed, ill, and you're at risk of developing a number of complications. Some of those may kill you. This was a slightly unfavourable review I got when I first arrived in Edinburgh. I'd like to reassure you it isn't actually true, but it acts as a good introduction to our topic today, which is looking at the complications of stroke which might kill you suddenly. And I'm going to be talking about deep vein thrombosis and pulmonary emboli in stroke patients. First of all, what are they? Why are they important? why do stroke patients get them, and how might we reduce the risk of them getting them? And also I'm going to talk specifically about one very simple treatment, stockings, which some of you may have some experience of. So what is a deep vein thrombosis? Well, this is one of the earliest pictures that doctors have drawn of deep vein thrombosis. This was drawn in the 1890s. And these are the veins and the legs, not the brain, the legs. And there's a great big clot here which is formed in the brain, in the vein of the leg. And if you get that, you might find that your leg gets really swollen, really painful, really red, really hot. That's a typical, very bad deep vein thrombosis. It can actually be bad enough that you actually lose your leg, but usually it's just very painful and unpleasant. So that's what a deep vein thrombosis is. That can result in a pulmonary embolus. Peter's talked about emboli going from the clots going from the heart to the brain. You can get little bits of that clot in the leg breaking off and going up into the heart and the lungs, and that's what a pulmonary embolus is. So pieces break off, and this is an MRI scan of the chest. This is the heart here, this is the left lung, the right lung, and this here is a big clot which has blocked the artery coming out of the heart. That could be big enough to stop the heart completely and cause somebody to die suddenly. If it's a bit smaller, it may simply cause you to be very breathless suddenly, it may cause chest pain, or it may cause you to get a cough and start coughing up blood. Those are the sort of symptoms of pulmonary emboli. A chap called Virchow, many years ago, described Virchow's triad. He said that you get blood clots due to three main factors. Stagnant blood flow, which is what Peter was talking about in the heart, where the blood is moving slowly, it's turbulent, and it clots. So that's one cause. If you injure the wall of the blood vessel or the wall of the heart, that encourages clot to stick to it and produce more clot. And then if your blood is stickier than normal, if it's thicker, if it's got too many clotting factors in it of certain sorts, then what you get is this, which is a solid blood called thrombus or blood clot. It isn't flowing anymore. People who get deep vein thrombosis are generally patients who are lying in hospital beds, immobile, people who have had major operations, people like you and I who go on long distance holidays to the southern continent and sit too long in our Boeing 747, maybe having too many drinks, going to sleep for several hours at a time. These sort of people get deep vein thrombosis, which may be complicated by pulmonary emboli. But patients who have had a stroke come into hospital, they're often immobile, they're often dehydrated, and they also can get deep vein thromboses. And this is a really big problem. This is the news in 2005 with a parliamentary committee pointing out that 25,000 people in the UK die each year of pulmonary emboli in our hospitals. And our hospitals throughout the UK and all throughout the world are obsessed with trying to reduce the risk of this complication. So what is the risk if you have a stroke and you're immobile and you come into hospital with a stroke? Well, for every 100 people, 5 will develop a big swollen leg, like the red one I showed you. That's a symptomatic DVT. However, if you look carefully at these patients, 17 of them will actually have a clot in their veins, although you don't always get the symptoms. So this is really a silent killer. You don't know it's there until you've had your pulmonary embolus and you die. What about pulmonary emboli? Well, every 100 patients coming into hospital with a stroke who are immobile, we will diagnose 2 people having a pulmonary embolus. Which doesn't seem very many. The problem is that if you look carefully at our patients with scanners like MRI scanners, actually, of every 100 patients we treat, 10 of them will have had a pulmonary embolus. So it's much more common than we think. And you can liken it to our iceberg, where most of the problem is hidden. It isn't apparent. And it suddenly jumps out at you and causes a major difficulty. And we often diagnose things like chest infections, or patients just got a fever, we don't know why. Many of those are probably due to deep vein thrombosis and pulmonary emboli, which we don't recognise, because it's quite difficult to detect. You have to think about it, and then you have to do expensive scans to find them. So what can we do to try and reduce the risk of this happening? Well, we can avoid immobility if we can, and we try to get people out of bed as quickly as possible and start moving them around, and we can hopefully stop them getting dehydrated by giving them plenty of fluids. So we try to reduce stagnation, we reduce the stickiness of the blood. Another way we can reduce the stickiness of the blood is to give anticoagulants. Heparin is a very common one. We give it by injection. This is heparin. This was discovered by a medical student, which is encouraging for some of you perhaps, in 1916. A very successful medical student, I'd have to add. And he discovered this stuff in the guts of animals and found that it had anticoagulant effects. And for the next 20 odd years, they were trying to get it right, and they were giving it to people, and it was having very bad effects and very dangerous stuff. But by about 1930, 1932, this became an established treatment which could be used to try and treat clots and prevent clots. However, in our patients with stroke, even those where there's been a blood clot, if you give these drugs, you will cause them to bleed into their brain. And this is another bleed into a brain, rather like the one that Peter showed you earlier. And this is catastrophic. This can kill you within a few minutes. So we generally, in stroke patients, we tend to avoid the use of heparin and other anticoagulants, especially in the early stages, but that's when they're most at risk of deep vein thrombosis. So we use other methods, physical methods, to reduce the risk, which don't have the complication of causing bleeding. You may recognise this chappie. He was just testing them out, this novel treatment, when he was visiting King's Hospital a couple of years ago. So these are graduated compression stockings. Here they are on a patient. And these aim to reduce the risk of DVT. Some of you will have tried these out, or something very similar, by using flight socks. So when you've gone off to your long holiday, you've bought these in boots before you leave, and you've put them on, and that, along with maybe a little aspirin tablet, you think you're protecting yourself. So how might these things work? Well, we don't really know, but the theory goes that these stockings, these things here, squeeze the ankle a bit more than the calf and a bit more than around the knee, and cause a pressure gradient up the leg, which encourages the blood flow to go back from the feet up to the heart. So this is the pressure gradient, and it's pushing blood up. That's one way it might work. How else might it work? Well, this is trying to decrease the stagnation. Well, the other theory is, and many of you will have tried this when you were younger, these things aim to compress the leg and the veins in the leg, so rather than being a big hole down the middle, and if you squeeze you get a sort of dribble, it squeezes it so it's a really narrow little hole, like that. And as you can see, the water really, I try that again, the water really runs very fast and is far less likely to clot. Sorry, Peter, it had a better range than I thought. So the theory goes that you squeeze the veins and you make the blood flow quicker, and then it doesn't clot as much. And here's a picture of that with a compression around the veins. It also makes these valves in the veins more effective, so the blood all goes in the same direction rather than different directions. So here we're trying to deal with reducing the stagnation of blood. It is also said that these support the veins and make them less liable to injury by just lying on them when your leg is still. It doesn't do anything really about the sticky blood. However, these things are not without their problems. They put pressure on the skin, And here are a couple of my patients who had stockings on. This is black, these are marks on the skin here where the skin has been damaged by the wrinkles in the stockings. And this patient actually went on to lose both legs through amputation because of the damage done to the skin. Here's a nasty ulcer which formed in a patient where the stocking rucked behind the knee and caused pressure on the skin and caused a pressure ulcer. Not nice. So these things cost money, but they also can have complications. Because of uncertainty, the guidelines which tell us doctors what we should be doing were rather chaotic in the early 2000s. The Royal College of Physicians of London in 2004 said, if you have a patient who is immobile after a stroke, you should apply stockings. Put these on. However, the Swedish guidelines at the same time said there's insufficient evidence to support their use, and Swedish doctors should not use stockings. And the Scottish guidelines in 2002 encouraged the clinicians in Scotland to put the patients into randomised controlled trials to test whether these things are actually effective, so we know what to do more certainly in the future, and we get rid of this variability in advice given to doctors and variability in how we actually treat patients. After all, you want to, as patients, all of you want to get the right treatment. You don't want to get one treatment and you the other just by chance or what your doctor believes at the time. So, back in the early 2000s, in 2001, we set up the Clots trial, the Clots in Legs or Stockings After Stroke trial. And this is a multi-centre, randomised trial to evaluate graduated compression stockings, and was funded by the Medical Research Council. I'm pleased to say that this is the first ever trial that they funded of lingerie. I didn't point that out when I was applying for the money, but I did after we'd finished it. It was also supported by Chest, Heart and Stroke Scotland, the Stroke Research Network and the Chief Scientist Office in Scotland. So these things cost quite a lot of money to do, but we're trying to answer an important question. And the best way to find out whether a treatment is effective is to do a randomised trial, and I'll tell you briefly how that is done. Our question was, a very simple one: do full-length graduated compression stockings reduce the frequency of DVT after stroke? To do this, we ran the trial from 2001 to 2009. Spend a quarter of my working life answering this one question. We had to involve 135 hospitals in 9 countries, and these are the countries involved, and 5,632 patients volunteered to participate to help us answer these questions. So what's the design of a randomised controlled trial? Well, in Clots Trial 1, which is the one I'll be telling you about now, 2,518 immobile stroke patients on day 0 to 3 of their hospital admission were randomly allocated to either having routine care and wear thigh-length stockings, those are the big long ones, these are only the short ones, or to avoid any stockings, and then they were followed up carefully, every patient, with a Doppler ultrasound here to detect clots in the legs. And the idea is that if you find out whether you get fewer clots in this group than this group, you will show that the treatment is effective. What's randomisation all about? Well, one way of randomising is to flick a coin. Heads you get the stockings, tails you don't. We don't actually do it that way very often. We generally use a computer, but it's the same idea. And if you do that in a large number of patients, you will end up with 2 groups who are pretty much identical in everything but the treatment they receive. They're the same average age, the same mix of men and women, the same degrees of immobility and severity of stroke, the same thickness of blood. All the things we can measure and all the things we can't measure should be balanced in those 2 arms. And then any difference in the rates of deep vein thrombosis in one arm compared with the other should reflect the difference in treatment which you're applying. This is how we find out whether any medicine, any treatment we have in medicine works. We actually set up a website which all of those hospitals could enter, and they press this button here, which is randomize a patient. They put the details of the patient into the website, and then the website says, give this patient stockings or don't give them stockings, and do the scans, please. And they enter the results of the scans also on this website, also how the patient was when they were discharged from hospital. So it's all run through information technology. What was the result? Well, here are the primary results of Clots Trial 1, which here's the rate of DVT in thigh-length stockings and avoid stockings. This is big DVTs affecting the big calf veins, the most dangerous ones. And you can see that about 10% of both groups got deep vein thrombosis. And that tiny difference there is not anything but other than chance. Okay? So this tells us that stockings are not associated with any reduction in the risk of DVT, whatever the Royal College of Physicians of London thought in 2004, and many doctors as well. Also, if you look at the proportion of people dying in each group, it was very similar. In fact, a slight tendency to more people treated with stockings dying than those without stockings. So it wasn't saving any lives. What it was doing is causing skin breaks, like the ones I've shown you. They were 3 times as more common with the patients having stockings than not stockings. And this is statistically significant. This is an important finding. So what do stockings achieve? Well, they don't prevent DVTs, they make people quite uncomfortable, and they cause problems. So what should we do with these? Well, they've got several uses, I found, because we've got large supplies. They also make quite nice dusters. Anyway, so at the moment we've rather given up on using these stockings, and certainly in most of the United Kingdom, the use of stockings in stroke patients has just fallen off dramatically. Why don't they work? Well, we don't really know. We know that they don't work in real life. Why don't they? Well, perhaps they were being applied a bit late. These DVTs can occur within a few hours of a person being immobile. And maybe the stockings being put on a few hours after that just don't stop them developing. They're quite complicated to use. This is a short stocking, but there are 28 sizes of stocking. And the nurses, when they apply these, will have to measure the size of your leg. And all of your legs are different shapes. It's be very surprising whether you will get a stocking which really fits you very well and gives you the gradients, those pressure gradients that we saw. So it may be that it's just unachievable. It works in the model, it doesn't work in the whole range of human beings. Also, they're pretty uncomfortable, and many of our patients just say, please take them off, I'm just too hot, too uncomfortable. Or maybe those theories about how they work are all wrong. We disseminated the results of our trial in the Lancet, Washington Post, New York Times, Nursing Times. So we tried to get the message out there as quickly as possible, and hopefully we have led to these stockings being used far less around the world. 80,000 people in the United Kingdom alone would be treated with the stockings if they worked. So we've stopped that use. The NICE guidelines, the most up-to-date ones, now say do not offer anti-embolism stockings for DVT prophylaxis in people who have had a stroke. So doctors now no longer use them. So what can we use? Well, the NICE guidelines suggest that we could consider something like this. This is a newer technology. You have these things. So you wrap these around the leg. They've got Velcro here. They're nice and light. They're attached to this pump, and you strap them on the patient's legs, and then they pump up. and they squeeze around the calf, then they squeeze around the knee, and they squeeze around the thigh, and gradually they milk the blood up, and they try and keep the blood flowing. So this is called intermittent pneumatic compression. As you can hear, they're a bit noisy, a bit irritating, and many of our patients think they're a bit too noisy to allow them to sleep. So they're not perfect, but maybe they will increase the blood flow, reduce the stagnation. They don't like being switched on when they're not on a pair of legs. They know they're not on a pair of legs. This machine's very clever. It measures the size of your legs, which is unfortunate for some people, and it squeezes a bit harder if your legs are a bit too large. So it's quite an intelligent box, not as expensive as Peter's machines. That's only £1,500 worth of box and about £30 worth of stockings, but they have to be thrown away every time. So at the moment we're doing the Clots 3 trial, which is recruiting 2,800 immobile stroke patients, just the same as in Clots trial 1, routine care with intermittent pneumatic compression in a void, and we're doing the Dopplers to see how many DVTs each get. We're going to finish recruitment in September 2012. This one will have only taken us 3 years rather than 8 or 9, because we're getting the hang of it now. And we'll report our results to be able to tell the world whether these things are any use in stroke unit care. Are these sorts of things value for money? Well, so each of these trials, the Clots 1 trial, the Clots 3 trial, will cost about £2 million to run over 3 or 4 years. However, if the NHS stops using stockings in stroke, it would save that money within a year, easily, just on the purchasing of the stockings, forgetting about all the time.
This production is copyright the University of Edinburgh.